Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. And welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour or so, and Spark Live is where we gather each Wednesday to showcase excellence and innovation from across the child and youth healthcare community to spark conversation, ideas, and action. And since we are live, I want to mention that you can probably hear the garbage trucks collecting the garbage outside our window for the next few minutes. But I also want to remind you that you do have the opportunity to type in questions during these live sessions. So type those questions in at any time. We'll check for questions potentially throughout the session, so don't feel you need to wait until the end of the session. Just type them in as you think of them. And also, always feel free to share your thoughts on Twitter, and if you do, be sure to tag us at Child Health Can. All right, before we get to start today's session, I did want to thank Mallinckrodt Pharmaceuticals for supporting our webinar program. They've been a supporter of Children's Healthcare Canada for many years, supporting our work in patient safety, quality improvement, family engagement, and they were interested in supporting some webinars that focused on the challenge of implementing change, various types of change, in a multidisciplinary environment, such as, for example, an NICU, a complex multidisciplinary environment. And for these webinars, we'll be talking about implementing things like new clinical interventions. In a couple of weeks, we'll be talking about implementing large, complex clinical systems. And at some point, we'll be talking about implementing devices and the challenges that go along with that. And once again, Mallinckrodt will be joining us at our annual conference coming up in Ottawa on December 8th to 10th. Registration is, of course, still open, and the program is on our website. But Mallinckrodt at the conference on Monday, December 9th, will be hosting a session focused on the successful and unsuccessful introductions of equipment. And they'll be looking at that from the perspective of administrators, from a patient safety perspective, from the perspective of different departments, and who should be included in the assessment team engagement strategies, all with the focus of optimizing patient safety. So hopefully you'll come to our conference in October, in Ottawa in December, and you'll visit them at their session while you're at our conference. All right, so today we're going to be talking about a new paradigm of physiologic-based critical care, and this is really along the line of that implementation of a new clinical approach within a complex multidisciplinary environment. And joining us today to talk about this, we have two individuals from Winnipeg, from the Children's Hospital in Winnipeg. We have Dr. Yasser Elsayed, who's an assistant professor, staff neonatologist, and registered echocardiologist at the University of Manitoba, where he established the innovative neonatal hemodynamics program, which integrates ultrasound, echocardiography, NIRS, and they're optimizing the management of critically ill newborn infants. And joining him is Dr. Shyamala Dakshinamurti, who is a neonatologist and biomedical researcher. She's also an associate professor of physiology at the University of Manitoba in the field of hypoxia, physiology, and persistent pulmonary hypertension of the newborn. So with that aside, it's my pleasure to hand the virtual podium over to Dr. Elsayed and Dr. Dakshinamurti. Over to you guys.
Thank you very much. Thank you, Doc, for the introduction, and welcome everyone. My presentation today will be about a new paradigm of physiology-oriented critical care. And I would like also to thank Shyamala for joining me for this presentation.
Happy to be here.
Thank you very much. So I have nothing to disclose in this presentation, and I have 4 main objectives over the next 40 minutes or so. First, I will introduce the difference between the physiology and evidence-based practice and how to integrate between both. And also, I will discuss the basic steps of body compensation to maintain normal oxygen delivery, and how to integrate clinical assessment, advanced monitoring techniques to formulate a physiologic-based medical recommendation. At the end, I will discuss the evidence supporting the physiologic-based approach and its impact on clinical recovery. So I will stop between objectives, and I will give a chance if there is any question, and also for Shyamala to comment. First, I will discuss the difference between physiology-oriented practice and evidence-based practice and how to integrate between both. Evidence-based medicine is targeting a single disease management, which is should be single disease, very clear pathophysiology or single pathophysiology, and it should be easy to randomize into 2 arms. But because if you have multiple pathophysiologists, then in this case, it might be difficult to randomize into 2 clear arms of intervention. That cannot be randomized simply if you have multiple pathophysiologists. So if there is if we have heterogeneity between different pathophysiologic mechanisms, then it would be really difficult to randomize into 2 simple arms of like to get a clear answer at the end. So as a trial to implement evidence-based medicine in the daily critical care, we searched for 68 questions in our neonatal intensive care unit related to daily practice. And these questions related to respiratory care, cardiovascular issues, neurological care, gastrointestinal and feeding issues, and prematurity. So as you know, there is a grading, acceptable grading for evidence, starting from evidence from multiple randomized controlled trials, at least 1 properly randomized. And then at the bottom, we have opinions of respected authorities based on the clinical experience. So that's the bottom of the evidence, and have in between controlled trials and the case controlled trials and so on. And we have also the quality. The quality, if you have very clear, strong recommendation from the evidence, that will give grading of A. And then if it is just fair, then we'll give B. And then at the end, we have insufficient data to recommend either with or against the intervention. So we had 68 clinical questions. And then you can realize easily that most of these questions fit in the bottom of the evidence, and less than half fit in the top of the evidence. So level of and the quality of the evidence that we have from the 68 questions, only 41% with acceptable level of evidence. I'm talking about level 1 or 2. And the quality, we have only small number, strongly recommendation, fairly recommended, 15 and 12, and most of the quality less than what we are looking for. So typically, at the end, we have only 14% with acceptable good evidence and good quality from all of the 68 important clinical questions. Typically, the evidence-based practice is integration between research, patient values, and the clinical wisdom, which I don't know exactly what's the definition of clinical wisdom. So typically, we got 14% only from research, and we left what's left over from to 100%, 86 with the clinical wisdom.
Perhaps we're not so wise.
Yes, yeah. But we need to make that physiologic sense. We need to have a clear definition. We need to understand the physiology and the pathophysiology very well to deserve the term of clinical wisdom. So it will be more clear if we have a clear the person or the clinician applying the physiologic-based make sense equations and integration at the bedside, not just relying on his clinical experience. So we created 7 steps of physiologic-based practice. Started from search for relevant physiologic fact. We have clinical question need to be answered, convert or clinical decision required, convert that into question, and then search for related physiologic fact or equation. And you can go directly from clinical decision if you have the physiologic fact very clear. And I will give examples for that. And then apply at the bedside. At the bedside, integrate all of the clinical diagnostic techniques, all of the monitoring techniques that you have all together to answer or to give you a physiologic makes sense impression. Identify the pathophysiologic mechanism to be targeted and formulate physiologic-based medical recommendation. Based on that, you may get a response. Then you will be sure that what you did makes sense physiological response, and keep repeat that again. Then you don't have to start all over each time. Once you have a very clear physiologic fact can be applied at the bedside, you can have your guidelines physiologic base, and you can repeat that again and again. And I'll give you case scenarios. So why evidence-based medicine cannot give a clear answer to all of the clinical questions? This had been actually discussed many times in literature, and the answer in most of the reported articles, negative results are often attributed to heterogeneity. Heterogeneity typically can be 2 types. So it can be related to pathophysiologic mechanism, or can be related to the pathway leading to similar outcomes. So if you have multiple diseases and altogether they are sharing in the pathophysiologic way leading to similar outcomes, then if randomized intervention to one disease, you might not get at the end a clear favorable outcome or bad outcome based on the intervention. So first example of the heterogeneity related to the pathophysiology. So we have, if you move over the patients in any critical care unit, including neonatal critical care, pediatric critical care, or adult critical care, they can be categorized according to oxygen delivery into 2 main categories. A category, patient at risk of hypoxemia. It means that the oxygen saturation not maintained well at the safe target level. It could be due to limited diffusion, right-left shunt, hypoventilation, pulmonary congestion, pulmonary hypertension, or VQ mismatch. So typically, pathophysiology related to lung or heart, or both at the same time. On the other hand, you may have issue related to hypoxia. And the hypoxia, definitely that you have infant or patient lacking oxygen at the tissue level. And it could be related to low blood flow or insufficient hemoglobin to carry the oxygen to the tissue level. So typically you have 3 main factors or contributing factors related to oxygen delivery: oxygen saturation, hemoglobin, and the blood flow. So if you have any issue with one of these, it might end up by low oxygen delivery. So blood flow can be related to low preload, low systemic vascular resistance, high afterload, poor myocardial performance, left or right shunt, and all of these factors might be presented the same by low blood pressure, for example, or lactic acidosis, but the management will be different. So treating infant with low systemic vascular resistance will be like opposite to infant with high afterload due to high resistance by physiology. Heterogeneity might be related to pathway leading to similar outcomes, and I will give you an example for that. In premature infants, they might be exposed to patent ductus arteriosus, necrotizing tuberculosis infections during admission, and all of these diseases might lead to inflammatory injury or reactive oxygen species, and leading to apoptosis at the end, very poor outcome. In our body, we have anti-inflammatory mediators to counteract the inflammation and pro-inflammatory mediators. on the other hand, antioxidant and pro-oxidant, and the balance between both will define at the end the outcome. So typically you have multiple diseases and they are sharing in the pathway, common pathway, and at the end might be difficult if you intervene to manage PDA and looking for the long-term outcome like chronic lung disease. You might not get a clear answer at the end because the pathway will be diluted by the impact from other diseases. What we know from evidence-based medicine in neonatal care regarding major outcomes, we know for sure that good for outcome, antenatal steroids, early CPAP, giving surfactant to RDS, breast milk, the record clamping, and that's it. That's what we know, that everything in the list is good for outcome. Bad for outcome, infection, inflammation, oxygen, hypoxia. So the hypoxia or hypoxemia and the medication that you are using to treat hypoxia, both of them are bad for outcome. Mechanical ventilation, cardiovascular instability, hypotension, and the medication that you are using to treat cardiovascular instability are also bad for outcome. So typically we need to define exactly what we need to treat, because longer exposure to this medication means worsening of short and long-term outcomes. So I'll be focusing on this list, oxygen and cardiovascular drugs. So before discussing some case scenarios, I have just to clarify the basic steps of body compensation to maintain normal oxygen delivery. We have in our body 3 systems. They are working all together to maintain normal oxygen delivery at the tissue level: the respiratory system, blood, and the cardiovascular system. And with decompensation of any one of these systems, or one or more, the body will compensate by maintaining autoregulation. So to maintain normal oxygen delivery, it is typically a release of nitric oxide at the tissue level to maintain higher blood flow. And then if the autoregulation has reached the maximum capacity to compensate, the next will be increased oxygen extraction. So the tissue will extract more from what's left over in the venous compartment to compensate for the increased oxygen demand. And there is a maximum level for that as well. At the end, if the oxygen delivery decreased to critical level, the tissue should rely on other mechanisms, which is anaerobic metabolism, non-oxygen metabolism. And then eventually you have cellular damage. So how to integrate clinical assessment, advanced monitoring techniques to formulate a physiologic-based medical recommendation? So we'll discuss the paradigm of physiology-oriented critical care. We have like 6 typical steps or mechanisms that can be used at the bedside. Blood pressure trends. Instead of relying on just blood pressure as the fixed numbers in like different intervals, we rely on the trend. And the trend will give us a very clear impression about the compensation. And the trend of systolic, diastolic, and pulse pressure, not just mean blood pressure or single parameter. Autoregulation, if you add blood pressure to a near-field spectroscopy, you'll understand the autoregulation threshold of low blood pressure. And then blood flow indices, you may need to get blood flow indices from other techniques like echocardiography and add to that near-field spectroscopy. If you integrate between all of them, you will get very clear impression about the physiology of hemodynamics. And then if you add respiratory functions, you will get a clear impression about respiratory physiology. And then regarding the brain assessment, point-of-care ultrasound for the brain, Doppler indices, resistive indices, near-field spectroscopy, EEG, integrate all of them, you will get also a clear idea about the neurophysiology. What about the intestine and the gastrointestinal tract? If you integrate between clinical biochemical markers, intestinal ultrasound that we are using as a routine assessment for infants with compromised intestinal performance, plus near-field spectroscopy, you will get very clear or more clear impression about the intestinal performance, instead of just relying on the routine X-rays or just biochemical markers. So let us discuss that in more practical way. So we have a clinical question to be answered. So what's the difference or what's the definition of hypotensive shock, which should be treated to prevent bad outcomes? So do we have an answer for that? Hypotensive shock is very common, a critical condition in all of the intensive care units, pediatric, neonatal, adult intensive care. Regarding neonatal intensive care, we don't have a clear answer from evidence. Just showing one of the articles published by the Neonatal Research Network in USA, and they included 16 different units trying to identify what's the definition of low blood pressure and management based on each definition, 15 different definitions. Antihypotensive, the conclusion from the study, antihypotensive therapy administration was not associated with improved in-hospital outcomes for any of the 15 definitions for low blood pressure. Of low blood pressure investigated. Alternative methods of deciding who to treat are needed to maximize patient benefit and minimize harm. So what's the alternative method? That's one of the research articles, and all of them, they agreed on the same conclusion. There is no any clear definition from evidence. We need to get an answer from physiology.
Part of the difficulty with this is that what constitutes evidence, strong evidence for benefit, tends to be outcomes that are fairly distal from the event that you are trying to treat. And so if you're trying to improve hypotension, and if we say hypotension based on the usual, oh, it's less than the gestational age, that's got to be bad kind of definition, there's no way for us to, you can't determine whether making blood pressure better now will improve survival long-term. And a good study tends to look at long-term outcomes rather than immediate, did the blood pressure go back up? Right. So that's where you start getting into heterogeneity of systems affecting your long-term outcome. You cannot use a long-term outcome to comment on the efficacy of a more proximal event.
Exactly. That's why when we are relying on physiologic-based practice, we are usually looking for short-term outcomes as a actually parameter of improvement. Long-term outcome, as we mentioned before, with the heterogeneity of the pathway, you may that's very difficult to get a clear answer at the end.
The only thing you can do is use long-term outcomes to caution for safety of your early intervention.
Right. Any question, Doug, from audience?
No, there are no questions at this point, but that's always my chance to remind the audience to type your questions in as you think of them. Anything that you've heard so far, or if you have any other questions that have come to mind, just type those in at any point, and then next time our presenters stop, we can have those questions available for them.
Okay, so we don't have a clear answer from evidence. What about physiology? So we'll apply the model that we described earlier in one of the slides. So we have a related physiologic fact. We have diastolic and diastolic blood pressure. We need to understand exactly what does systolic blood pressure mean. So systolic blood pressure created by ventricular contractile function to exceed vascular resistance, which is afterload. And that's a pressure needed to push the blood out of the heart. Diastolic blood pressure is the resistance created by contractile property of arterioles. So typically that's reflecting systemic vascular resistance to maintain higher pressure gradient at the arterial side, so blood keep moving back to the heart. The diastolic blood pressure is reflecting two things: either resistance by vascular arteriolar vascular resistance or intravascular volume. For systolic blood pressure, it means normal systolic blood pressure, it means you have normal venous return, normal myocardial performance, and stroke volume. Normal diastolic blood pressure means you have normal systemic vascular resistance and overall vascular volume. Overall volume on the body considered as normal. So if we have abnormal systolic blood pressure, it means that we have one of these issues. If we have abnormal diastolic blood pressure, then we have either low vascular volume or low resistance. Let us apply that on the trend. So just did a screenshot from one of the patients showing that the three lines, as you can see here, that's a trend of blood pressure over time. And the trend of blood pressure is reflecting 3 lines. The bottom line, diastolic, the middle is mean, and the top is systolic blood pressure. And you can recognize easily that the blood pressure trend is going down. That was associated actually with the increased lactic acidosis. And you have maintained normal pulse pressure. As the blood pressure going down, you have pulse pressure normal. It means that the systolic blood pressure maintained normal. It means that you have normal myocardial performance and normal cardiac output and the stroke volume. What does that mean? It means that you don't have to give any inotropic support or medication to improve heart performance. You need to improve the vascular resistance. So typically you need vasopressor as a first line. Vasopressor, it means that you have alpha stimulant more like norepinephrine. Another screenshot from one of the patients. So you can recognize easily that the pulse pressure narrowed. All of a sudden, blood pressure increased actually, not decreased, and the pulse pressure very narrow. And that was associated also with lactic acidosis. That's because of increased vascular resistance. Typically, you need to give vasodilator. So that's opposite to the previous example. So not all of the infants or children with a low blood pressure, they should be treated the same. It's based on the physiology, and the physiology in this infant very clear that this infant needs vasodilator. And after applying vasodilator, you can see easily that the pulse pressure, the distance between diastolic and systolic widen gradually with improvement. A third example, you have blood pressure dropped and narrow pulse pressure. You have everything bad. That's infant who's collapsing. He collapsed at 10 o'clock in the morning, as you can see in the screen, and picked up at 3 o'clock because the bedside nurse, unfortunately, was just looking at the mean blood pressure, and mean blood pressure was maintained. It was masked, normal. And the lactic acid increased at 3 o'clock. Pulse pressure was very narrow and started to widen after the start of epinephrine. You have low blood pressure parameters, including narrow pulse pressure, so you need a dual medication like norepinephrine, medication working in both alpha and beta stimulant. So you need to improve the heart performance and you need to improve the resistance at the same time. So blood pressure trend by histogram. There's another way to look at the trends of the blood pressure and to convert that into physiology. So any vital sign in our body can be represented on the monitor as a histogram, and the histogram will normally be looking as normal distribution curve, and it will give you a percent. So each bar representing a number, and the number is representing the percent of time that the blood pressure range here, like 29 blood pressure, diastolic blood pressure, 2% of the time, and each 1% is 15 minutes. So that's exactly the statistics for last 24 hours blood pressure trend. You look at this infant, systolic blood pressure, this infant was term, and systolic blood pressure should be more than 46 or 47, and you have 24 hours trend. All of the blood pressure time below the 46, and for the last 4 hours still below 46, last hour still below. So the trend for over time is still the same, below the acceptable normal level. If you have the opposite, infant 24 hours blood pressure was low, and then it started to improve in 4 hours and improved more 1 hour, you don't have to do anything. It means that he's compensating himself. You don't have to intervene. So that's one of the examples how to rely on the trend and the statistics making. Hypotensive shock below threshold of autoregulation. We can rely on the another machine here, which is near-field spectroscopy. So the number on the machine here, 70, is reflecting the venous compartment, the venous saturation. So you have just part of the picture. If you have the arterial saturation, and the other part of the picture, which is really important, the venous saturation, and the difference between both is how much consumed by the tissues, how much is extracted. Normally 15 to 30% should be extracted normally by any tissue. If you have high extraction, it means that you have low blood flow. So the tissue trying to compensate by extracting more. So this number will be getting lower. Lower than 60 or 50 means that the tissue is trying to compensate by taking more oxygen from the venous compartment, and that could be due to low blood flow, anemia or low arterial saturation. And you can see the trend here. And so the y-axis representing the brain oxygen saturation, and the x-axis representing the time. You can see with the drop of blood pressure, so the blood pressure compromised narrow pulse pressure, dropping blood pressure, and was associated with drop of the brain saturation. So the brain is trying to extract more blood to compensate for the low blood flow. And once the blood pressure improved after start of epinephrine and pulse pressure widened, the brain saturation improved from 50 or 50s to 70s back to normal. So the standard method of monitoring, we don't have actually, based on the definition of what's the best monitoring technique, we don't have this monitor available in any unit. So the definition of the standard, the best method of monitoring for hemodynamics should be non-invasive, continuous, available at the bedside, accurate, real-time, reliable, quantitative results can be directly interpreted in physiologic terms. That actually does not exist in reality. There is no such monitor. That's why we try to integrate between different monitors to get more clear answer. So typically in our unit, we are using this model of integration, targeted natal echocardiography, the echocardiography performed by clinician, clinical evaluation by chemical markers, monitoring of oxygenation, including arterial and tissue oxygenation, non-invasive cardiovascular monitoring, invasive, integrate all together to formulate medical recommendation at the end. So the integration is the key of success to get a clear answer about the pathophysiology. So I will, before moving to the next question, I would like maybe ask Shyamala if you would like to comment on anything, or if there is any question.
Well, the notion of using physiology as part of our approach to newborn evaluation is one that in Winnipeg we've taught for some time. It's not necessarily as painful as it sounds, and the use of the alveolar gas equation to determine what is the ideal amount of oxygen that on a given FiO2 should be available in the arterial blood. And then you compare the ideal amount to the measured amount and determine your AA difference. This is the first step of taking respiratory physiology to the bedside.
Yeah.
And if you then analyze how much oxygen should be in the blood versus how much oxygen is in the blood, you then move that on to how much oxygen can be extracted and how much oxygen is being extracted, which is your tissue diffusion and tissue oxygen delivery.
Yeah.
These, in the old days, we would theoretically do venous blood gas and an arterial blood gas and compare them. We now have so much better methods of determining what is oxygen extraction, oxygen delivery, and oxygen utilization, using near-infrared spectroscopy, using end organ function and biochemical markers thereof, and integrating that with your clinical sense of what's going on with the patient. These parameters are as useful as we will get in a baby who's sick. We'll get a CBC, we'll get a CRP, and we'll use these to determine whether or not we think that baby is septic or not. In a similar way, we should be using physiological markers of end organ function to inform our decision as to how to support the hemodynamics. So I think the approach of integrating all of these things is not new, but it's a way of thinking that I think perhaps has left us for some time.
Yeah. Doug, any question so far?
Nope, there's no questions yet.
Okay, good. So what's a safe target oxygen in preterm infant based on the Canadian oxygen trial? So that's another very important question. In preterm infants, if you are not really familiar with the physiology of preterm infants, they are very sensitive to oxygen toxicity. So that might actually induce a lot of bad outcomes, including retinopathy of prematurity and poor brain neurodevelopment, exposing the brain to the oxygen toxicity and oxygen-free radicals. So there was a question from the Canadian oxygen trial. And the oxygen formulated in the P-code format in infants born at 23 to less than 28 weeks gestational age does target oxygen saturation, which considered like low target saturation, 85 to 98%. So the bedside nurse try to maintain oxygen saturation within this target, compared to higher target saturation, 91 to 95%. And the lower target saturation might be associated with increased or decreased risk of death or neurodevelopmental disability at corrected age of 18 months. Not only the Canadian oxygen trial, all of the worldwide oxygen trials, including the trials done in US, New Zealand, Australia, UK, none of them was able to define what's a safe target saturation. So that's kind of heterogeneity in pathophysiology, and also the pathway leading to similar outcomes. So they are looking to improve the outcome, long-term outcome, based on the understanding of the impact of oxygen saturation on the brain. So trying to limit the oxygen-free radicals and the impact of hyperoxia on the brain development and development of retrogressive prematurity. So I'll just read with you the American Academy of Pediatrics conclusion based on that, which is really very gray and vague. Recent RCTs suggest that targeted saturation of oxygen saturation range of 90% to 95% may be safer than 85 to 89%, at least for some infants. So the idea, how to define some infants?
This is the crux of the matter, isn't it?
Yeah.
Because in real life, patients are very heterogeneous, where in the lab, the subjects are typically very homogeneous. It's, all the rats are coming from the same litter. In the real life context, we assume that the within group variability is going to be huge. And in the lab, the within group variability is generally curtailed. It's maintained as very small. So this is why clinicians and scientists tend to debate about what is an appropriate source of evidence, because somebody coming from an evidence-based medicine background would argue that there's no point in taking lab-based data as a source of how to understand what's going on in a heterogeneous clinical population. Whereas a scientist would argue that there's no point in looking at a heterogeneous population and thinking you'll ever get an answer.
Yeah.
So how do you determine which of the large group of different pathophysiologies here, which are the some infants in whom you will improve their outcome by setting their oxygen target higher?
Or lower. Yeah, if needed. So that's actually we will try to answer that by physiology. And to make it more clear, I have a case scenario, which is kind of common case scenario among the neonatal intensive care units. We have a baby girl born at 26-weeker, post-menstrual age 35 weeks. And she had ventilator-associated pneumonia, and she stayed on 100% oxygen for almost 10 days. And the clinical team tried to maintain oxygen saturation between 90 and 95%, with assumption that it could be related to pulmonary hypertension. And this infant was on mean air pressure of 14 on high-frequency ventilation. And that's X-ray. So that's typically X-ray consists of chronic lung disease. And we did echocardiography, and echocardiography did not show any sign of pulmonary hypertension. If you're not familiar with echo, that's a four-chamber view of the heart. That's a left mirror image. So that's a left side, right side. Left ventricle is more dilated compared to right ventricle, which is that's opposite or against the assumption of pulmonary hypertension. And that's a physiology of ventilation perfusion mismatch. Typically, we should have normal lung, well inflated and perfused with a like equivalent amount of blood. So if you have almost 5 liters of air coming in and out of the lung in 1 minute, so typically you have almost equivalent amount of blood coming in and out of the lung and leaving the lung within 1 minute, which is, we call it the ventilation perfusion matching. And ventilation perfusion matching is close to 1%. In real life, it's around 0.8. But if you have the ventilation capacity decreased, then they have the ratio now is decreasing 0.6, 0.4 until you reach no ventilation at all, 0/1, which you have infant with solid lung. There is no any ventilation, and the blood is leaving the lung with no saturation, or no, the saturation is the same as the blood coming to the lung. We call this condition right to left shunt. So we have grades of V, ventilation perfusion mismatch, and we have at the end the extreme, which is a ventilation, which is a right to left shunt. Typically, that's in any parenchymal lung disease, like lung collapse, pneumonia, chronic lung disease, lung congestion. On the other hand, if you have perfusion is decreasing, then and the ventilation maintained, the number will be increased, a ratio will be increased 1.2, 1.4, and until you reach at the end, you have reached at the end, there is no any blood, and the air is coming in and out without getting any exchange through the blood. So that's similar to the dead space physiology.
The distinguishing between shunt ventilation and dead space ventilation is possibly one of the most difficult aspects of newborn physiology and also ICU physiology generally.
Yeah, exactly. And will be just with the next slide might be more clear. If we assume that we have lung well inflated, and we have 50% of the lung of the both lungs, which is like one lung totally collapsed. So the blood coming to the healthy lung, 75% saturation and leaving 100% saturated. But the blood leaving the collapsed lung, the same as the blood going to the lung. So leaving 75, there is no any saturation increase. So the average between both is 87. If you give oxygen to this infant, trying to increase the 86 to 90 or above 90, which is the target saturation, that's impossible. So there is no, the number will not be increased because the other healthy part of the lung or the other healthy lung is working at the maximum.
So there is a fixed component here of unsaturated blood that will necessarily mix into the saturated blood.
Yeah, exactly. And then if just to give a clinical scenario, we have the same infant here we're talking about. So the 30, we have the y-axis representing oxygen saturation from 75 to 100, and we have the oxygen inspired oxygen fraction. So the bedside nurse tried to increase the saturation from 87 or 88 to above 90, but the right to left shunt was significant, more than 30%. So keep increasing the oxygen and there is no response, up to 100%. But what we did, if we win the oxygen back to 50%, we'll get the same result. Saturation will be the same. So typically you have like significant right to left shunt. At the same time, we monitor the brain by brain oximetry, tissue oximetry, and with weaning the oxygen back to 50, the brain saturation stayed the same. And it means that we just exposing the brain to a higher oxygen unnecessarily, and the brain saturation on lower target saturation was maintained the same.
At a physiological level, the rationale for this is that in a VQ mismatch, the component of blood that is seeing a gas exchange surface cannot exceed 100% saturated.
Yeah.
Where the component of blood that is going to a poorly oxygenated gas exchange surface will remain at a venous saturation. And so the admixing of the two, depending, if you've got half of the blood going to the collapsed lung and half of the blood going to the ventilated lung, then you have 50% of the blood that is coming with a saturation of 75% equivalent to venous, and 50% of the volume is coming at 100% saturated. No matter how much you crank up the oxygen, that number is still going to be 100% saturated.
Yeah.
So the mixture will always be proportionately roughly around 87%, and you cannot go higher unless you increase the fraction of blood that's going to the oxygenated lung. So in other words, unless you decrease the shunt fraction,
Yeah,
you're never going to resolve this.
And to do that, you need to inflate the collapsed lung or collapsed part. So there's a software that you can apply. Like there is no enough time to go over the software in details, but just we can get a number by applying the oxygen reduction test. So what we did exactly in this model, we applied the oxygen reduction test. We reduced the oxygen from 100 down back to 50 as far as it's tolerated by the brain, and applied that into a software, and we got actually the right to left shunt fraction and the VQ mismatch, which was 0.21. That's really a significant VQ mismatch, and right to left diffraction was between 25 to 30%. So Formulated make a recommendation based on what we did to accept lower target saturation. So this actually, as described in American Academy of Pediatrics, some of the infants might not actually fit into the higher target saturation. So we accepted lower target saturation, and we were able to wean the oxygen down as far as the brain saturation by near-field spectroscopy maintained within the target. So we kept the oxygen saturation 85 to 90, and within 2 days, the FiO2 weaned to 40%, down to 25%, and extubated to CPAP within 7 days. Lessons from this case: intrapulmonary right to left shunt might present clinically as similar to pulmonary hypertension. Weaning oxygen is a challenge in cases of significant right to left shunt and significant lung collapse. Near-field spectroscopy is a new technology that can help weaning oxygen and protect the brain from hyperoxia. So I finished with this case scenario. I'm not sure, Doug, if I have time to continue with the last case scenario, or would you like to maybe?
We do have just a couple of questions. So if you don't mind taking these two questions, then I'm sure there'd be time to continue on with the rest, if you don't mind.
Yeah, sure. Go ahead.
So actually the second question that came in was just asking if there's online access to the VQ mismatch software. Is that accessible, or?
Yes, it is accessible, and probably I can share with you the link.
Okay, if you can, if you do have time to sort of talk and type at the same time, there's a little chat box there in your control panel. If you can cut and paste the link in, we can send that out to the audience for them so they can have access to that.
Sure.
The other question was, you had 3 slides where you were talking about making a choice on inotropes based on systolic, diastolic, and mean trends, etc.
Yeah.
The question is, how do you interpret this in the presence of PDA, which affects diastolic, and also in consideration of other factors such as myocardial ischemia secondary to asphyxia or sepsis affecting SVR, etc.?
You can think about the cardiac function in 2 models. If we think about the volume of the cardiac circuit, we're thinking about the venous return curve, which constitutes it includes the mean systemic pressure, which is the pressure exerted by all of the volume inside the circuit, and the resistance to venous return, which as neonatologists we're really notorious for messing with by turning up the PEEP. The other aspect of it is the one that we're much more familiar with, is the Starling curve of cardiac function. Cardiac function and venous return are the 2 elements that create hemodynamics. And that while we're measuring them all together, we're trying to analyze them as 2 separate things. So to improve cardiac function, you want inotropy. To improve venous return, you want either changing the size of the pipe, in other words, decreasing or increasing the systemic vascular resistance, or increasing the volume of the pipe, which is to say either increasing volume by infusion or increasing the return of volume from the venous compartment, which is a venopressor. Or reducing the resistance to venous return at the thoracic inlet, which is to say turning down the PEEP. All of these are physiologic elements that are reflected in the hemodynamic assessment by TNE.
Right. Yeah, that's very good, like physiologic explanation. And I would like just to add a hint from the clinical point of view as an echocardiologist. So, if you have a normal pulse pressure, in infants with low blood pressure, it means that you have low systemic vascular resistance. probably you can consider to use vasopressor without asking for confirmation from echo. Once you have narrow pulse pressure, which would be due to decreased venous return or pulmonary hypertension or impaired myocardial performance, once you have narrow pulse pressure, then it is mandatory. You need an answer from echocardiography. You need to check the heart performance, venous return, cardiac output by echocardiography.
What I might suggest is the first question when someone gives you a blood pressure at the bedside, and often someone will tell you, well, the mean blood pressure is this. You need to know what's the systolic and what's the diastolic, and then you need to go to the monitor and trend. What is the blood pressure low because of the systolic, or is the blood pressure low because of the diastolic, or is it both?
Exactly. Yeah.
Because the mean is a calculated number sitting in between those two measured numbers.
Right. Yeah. So, and as I mentioned before, that the trend, you have the ability to check that back to 24 hours in any monitor available. The monitor is recording every 2 seconds, so you can go back the trend over 24 hours. If they have the trend is improving, then it is a good sign. If you have the trend is worsening, then to check which one is worsening more, diastolic or systolic, and also the pulse pressure.
For example, in an infant with patent ductus arteriosus, the diastolic pressure is likely to drop. And that's because the capacity of your circuit is now much larger because it includes the pulmonary circuit as well as the systemic.
And pulse pressure would be normal or even higher than normal, will be wide pulse pressure.
And that's because myocardial performance often goes up to compensate for the enlargement of the circuit capacity. So your pump function is better and your diastolic blood pressure is lower because of the larger capacitance. The only reason to address that is if overall your tissue oxygen delivery is impaired by that.
Very good. So do we have time, Doc, to carry on with the next case?
Yeah, we've got about 5 minutes left in our scheduled time. If we go over a little bit, that's fine too.
Okay, so the last case scenario, we have a preterm infant born at 31 weeks with congenital heart block. So the heart rate was between 50 to 55 beat per minute. And the cardiologist deferred the pacemaker because the infant was clinically stable. And as per guidelines of the heart rate maintained above 50 and clinically stable, then the pacemaker can be deferred and then until the baby grows up. But the baby developed multiple events of bloody stool at around 43 days of age with normal X-ray. So there is no any issue with the necrotizing enterocolitis as per the X-ray report. And the infant was otherwise stable in level 2 nursery. Hemoglobin was 82. And lactic acid was 2.3, which is still like within the acceptable range. That's capillary lactic acid. So the question is now, with the hemoglobin of 82 for this infant, transfuse or not to transfuse? If we try to answer the question from literature, and typically we try to avoid transfusion unless the infant is critically unstable or the hemoglobin is very low. But if you're looking at the physiology, the answer might be different. So most of the neonatologists might stay tight if the infant nutrition is optimized and the retics count is still okay. But we did part of the assessment in standard ultrasound, and in the ultrasound report, I will not go over the details, but just reading the final conclusion. And this actually report is part of the point of care assessment. It's not by a radiologist, it's by one of the neonatologists trained in standard ultrasound. So impression of compensated chronic ischemia affecting right bowel more than the left was compensatory hyperemia. Bleeding might be due to necrotizing or necrotic mucosal sloughing. Typically, 2 days after, the bedside nurse noticed that with the stool there is a sloughed mucosa in the diaper. So this technique includes assessment by ultrasound, Doppler, and near-infrared spectroscopy to assess the intestinal decompensation due to ischemia. So if you calculate oxygen delivery in this infant, and oxygen delivery we know from the medical school, but we need to apply that at the bedside, that cardiac output multiplied by hemoglobin multiplied by saturation, you will get the oxygen delivery. Cardiac output typically in this infant was low because of low heart rate. Heart rate is multiplied by stroke volume, and we'll get the cardiac output. Typically, the normal cardiac output in infants should be between 150 to 300 ml per kg per minute. So that's typically low cardiac output. Hemoglobin, just convert the hemoglobin to milligram per liter. And saturation, you will get the oxygen delivery, calculated 10 ml of oxygen per kg per minute. Typically, we need normal between 20 to 40 ml of oxygen per kg per minute oxygen delivery.
So this kid had two hits here. One, that the low heart rate resulted in low cardiac output, and that the low hemoglobin, while age appropriate and as the nadir, was insufficient to deliver enough oxygen given that low cardiac output.
Exactly, yeah. So, but if we look at the hemoglobin separated, probably we defer the transfusion. But this infant required transfusion. We calculated the cardiac the oxygen delivery that might be safe to perfuse the intestine based on also on the neurophysiologic spectroscopy assessment. So we need to get the hemoglobin as high as 110, and then try to arrange for pacemaker insertion. By doing that, by transfusing and maintaining hemoglobin up to 110 in this particular infant, we would get the oxygen delivery close to 14 or 15, which is just at the safe level to maintain oxygen delivery and to prevent ongoing damage of the intestinal mucosa. So lessons from this case: calculating components of oxygen delivery altogether was helpful to diagnose chronic ischemia in this case. And the common organs affected by chronic ischemia are intestine and the kidneys. In this case, we investigated the oxygen delivery and oxygen consumption by neurophysiologic spectroscopy, and it was really significantly compromised in intestine and kidneys, and improved after transfusion. So the infant referred as per the physiologic report to urgent pacemaker after that, and the cardiologist accepted to insert pacemaker based on our conclusion. So evidence supporting our physiologic approach. So I have just a few slides to go over some of the articles that we published to validate the impact of relying on the integrated approach. So we investigated our approach over 2 years compared to 2 years before we implemented our integrated approach. I just selected 340 patients with low blood pressure or hypotensive shock. In Epoch 1, just treated as per the
cookbook.
Cookbook? Yes, cookbook. Just relying on mean blood pressure, and there is no echocardiography, there is no near-field spectroscopy. Compared to another 158 patients, the time to clinical recovery is reduced 50%. So less time to clinical recovery, less exposure to cardiovascular medication, to interventions, less number of deaths, but that's actually inaccurate because of the small number. We cannot just rely on the small number to say that we reduce the number of deaths. But typically, the important outcome was we reduced 50% time to clinical recovery. There's another article just to show the technique itself and details of calculating oxygen delivery at the bedside and how to use the integrated approach to get more clear answer and more case scenarios, if you're interested to read more case scenarios. And we actually investigate and all of other oxygen indices and physiologic calculations at the bedside. So it's not really difficult. You need just to be trained how to do targeted echocardiography, how to calculate cardiac output, how to use near-field spectroscopy, and more knowledge in physiology. If you're interested to attend our workshops, we are organizing 2 workshops next year in Banff. One of them is related to point-of-care ultrasound and how to deal with a crashing infant by applying multi-organ emergency assessment of brain, heart, lung, abdomen in one protocol assessment for crashing infant by ultrasound. And neurophysiology is the same technique in more details about neurophysiology, hemodynamics, and respiratory physiology, how to use an integrated approach for these three different systems. Just for the sake of time, I focused on the hemodynamics and respiratory physiology. Probably in the future, if we have a chance, we can talk more about the neurophysiology in more details. Just to conclude at the end, integrated evaluation of neonatal physiology. Is a physiologic analysis of all of the respiratory cardiovascular markers, systemic and regional oxygen indices, aiming to understand the pathophysiologic mechanism of hypoxia and the stage of compensation. This should lead to formulating a physiologic-based medical recommendation. And again, in absence of clear evidence, search for physiologic sense. Thank you very much. And I'm ready for more questions, and Shyamala to comment.
So we are just about out of time, and we don't really have time for any more questions. But I just want to thank you for a great presentation. I mean, it really is an interesting approach that takes a much more holistic view of the patient, which is always always a great way to approach it. So before we sign off, I just wanted to give you any last minute or last comments you'd like to make to the audience, any closing key messages you'd like to leave them with before we move on. It's great that you showed a couple of other opportunities to see your work out in Banff, a beautiful place to go if anyone is interested. I encourage them to follow up and attend those sessions if they're interested. But is there anything else you'd like to leave us with, either you or Shyamala? If you have any closing messages for the audience before we go.
For sure, Shyamala, go ahead.
I would say that in newborn care, the early days of a newborn's life, there are more moving parts than are ever present in a human being for the rest of their lives. So in this very rapidly transitioning system, it is very difficult to find a fixed point that you can investigate by the method of evidence-based medicine. And so we have to use physiologic-based approaches in the absence of evidence, because there is no moment in which all of our patients have comparable physiology. Yeah. And so because of the heterogeneity of our population, I think all neonatology has always been physiology-based. We just may not be conscious of it.
Exactly, yeah. So the physiology is available and has been investigated in a lot of very well-designed animal research or even clinical research. But we need to apply that at the bedside. We need to understand the value of physiology, and we need to apply that. And it's not really difficult. And already you will enjoy it. Once you understand the physiology, apply and see the results, you will enjoy applying that. I would like to thank you, Doug, and the organizing committee. And I will provide you with my email and Shyamala as well. And if any one of the audience would like to ask us any question, feel free to contact us at any time.
That sounds great, and we will put that information on our website. As most people that listen to our webinars know, we do them every Wednesday at 11 a.m. Eastern time, and we do record these sessions and make them available after the fact on our knowledge exchange network at ken.childrenshealthcarecanada.ca. And we'll put the recording will be available usually by Friday, and any links to the slides, your contact information, and everything else here we'll put up on that webpage. So thank you again to both of you for such a great presentation. It's really a novel and interesting approach to this, and I think you're right when you said it's sort of how neonatology has always worked from that physiologic sense. But it's great that you can sort of put it into a nice framework like this, and we look forward to hearing more from you. In 2 weeks, we will have this second part of this mini-series on October 30th, where we will continue this conversation about implementing new and novel clinical interventions, clinical systems, etc. We'll be talking to our colleagues from the Hospital for Sick Children in Toronto about their experiences in implementing a hospital-wide electronic health record, and how that type of a system implementation brings a lot of opportunities to learn about implementation in general, and engaging a multidisciplinary team. But next week on October 23rd, we'll be welcoming Faye Johnston and Lisa Lachance, who will look at stigma and other barriers to accessing healthcare services for individuals that identify as LGBTQ2+, and that results in them experiencing poorer health outcomes and accessing care less frequently. And they'll be focusing on what organizations can do to make their services more inclusive and accessible for these individuals. So thanks again to everyone for joining us today. Don't hesitate to sign up for our Children's Healthcare Canada Spark newsletter to stay up to date with both our webinars and everything else we're doing at Children's Healthcare Canada. Thanks again to Mallinckrodt Pharmaceuticals again for their support in this webinar program, and hopefully we'll see many of you back here next week. Bye, everyone.
Yeah, thank you very much.